Hi, good day everyone. I am Dr. Jonna Muego and I'll be discussing the adrenal glands or what we call or otherwise known as the suprarenal glands, which are composed of your cortex and medulla. So the first part of this presentation or this discussion is the adrenal cortex. So the following are the objectives for this topic. To start with, your adrenal glands are actually paired pyramid shaped organs atop the kidneys. They weigh about 4 to 6 grams. Now, your adrenal glands are actually composed of the cortex and the medulla. So the cortex comprise the 80 to 90%, and this is a glandular tissue derived from the embryonic mesoderm or the mesenchymal layer. And for the medulla, it's actually comprised the 10 to 20%, and this is formed from the neural ectoderm and can be considered a modified sympathetic ganglion. Now, the cortex synthesizes and releases your steroid hormones, or otherwise known as your corticosteroids. The different corticosteroids are produced in each of the following layers. So, we have three layers: the glomerulosa, fasciculata, and the reticularis. Now, for your adrenal gland, di ba? We've already mentioned that this is composed of your cortex and the medulla. So for your cortex, these are composed, no, or I mean, this is composed of the following three layers. First layer is the zona glomerulosa. This is the outer 10%, and they have a low cytoplasmic to nuclear ratios and small nuclei with dense chromatin with intermediate lipid inclusions. The zona fasciculata is actually the middle 75%, and the fasciculata cells are cords of clear cells with a high cytoplasmic to nuclear ratio and lipids laden with foamy cytoplasm. The fasciculata are also generate androgen precursors such as your dihydroepiandrosterone, which is sulfated in the innermost zona reticularis layer. Meanwhile, no, on the other hand, zona reticularis is the inner 15%, and this zone is sharply demarcated with lipid deficient cords of irregular dense cells with lipofuscin deposits. Now, the adrenal cortex are classified, no, are or produce hormones which are classified as the following. For the glomerulosa, hormones produced are classified as mineralocorticoids, and the prototype or the major hormone produced is your aldosterone. For your fasciculata, the hormone produced is your glucocorticoids, and the major hormone is the cortisol. For your reticularis, the um, hormone is classified as the gonadocorticoids, and the major hormone is the dihydroepiandrosterone sulfate. Now, for this illustration, whenever there's stimulus, your hypothalamus, for example, let's just say stress. During stress, your hypothalamus will produce the corticotropin releasing hormone, which would in turn stimulate your anterior pituitary gland to produce your adrenocorticotropic hormone or your corticotropin. Your ACTH will actually produce your cortisol during stress, which would in turn help elevate glucose levels. No? And aside from producing cortisol, this would also, for example, another stimulus. During times of low blood pressure or low blood volume, your kidneys will actually sense this kind of stimulus. No? So the kidneys, especially the juxtaglomerular cells, will produce your renin. This is actually an enzyme. And this will in turn activate your RAAS. It's actually, di ba, familiar na ang RAAS sa inyo, guys. RAAS is actually the renin-angiotensin-aldosterone system. So whenever RAAS is activated, it will eventually um, produce your aldosterone. So your aldosterone hormone will stimulate the sodium resorption by the kidneys and also eventually lead to the secretion of your potassium and also the hydroxy ions, no, na secretion, which would help in elevating blood pressure and eventually elevating your blood volume. Now, the adrenal cortex also produce your androgens. The androgens support your anabolic metabolism or your gametogenesis. No, in times of meiosis, no, to produce another living organism. So these androgens will support gametogenesis. Now, for this illustration right here, the how ACTH is secreted, the corticotropin releasing hormone will actually bind with the receptors in the cell membrane. So think of this illustration here, you know, as the cell. So this figure here is the cell membrane. Now your corticotropin releasing hormone will bind to the cell receptors, which will actually no these are actually coupled by the this one adenylate cyclase by the stimulatory G proteins. The adenylate cyclase um, is stimulated, and this will in turn lead to the rise of your cyclic adenosine monophosphate in the cell. Now the CAMP or the CAMP will in turn activate your protein kinase A, which would then phosphorylate the P proteins involved in stimulating ACTH secretion, and also the expression of your POMC gene, your propiomelanocortin gene. And the proteolytic processing of your propiomelanocortin occurs in the secretory granules, where it is split further into several hormones such as your ACTH, your adenocorticotropic hormone, and your beta LPH or your beta lipotropin. Now that's for the secretion of your adrenocorticotropic hormone. So for this structure right here, this is actually a cholesterol structure, and this is the parent compound for all steroid hormones. And this structure is modified by enzymes to make steroid hormones such as your aldosterone, cortisol, and your estradiol. For the synthesis of your steroid hormones, they're actually the cholesterol. The steroids are actually derivatives of your cholesterol, and cholesterol is formed from the lipid droplets in cortical cells, and the removed cholesterol is replenished by cholesterol from LDH in the blood or can be synthesized from the acetate. So these are the sources of your cholesterol in the body. So let's recap. Cholesterol can be made within the cell from the acetyl coenzyme A, which is part of your de novo synthesis, and also can be taken up by the cell in the form of LDL. Not so the LDL, it will bind to the receptor to be taken inside into the cell to make your free cholesterol. So these are the sources for your cholesterol. For this one, steroid hormones are synthesized and secreted on demand. They are not stored. The first and rate-limiting step in the synthesis of all steroid hormones is the conversion of cholesterol to pregnenolone by the enzyme cholesterol desmolase. Now, the newly synthesized steroid hormones are rapidly secreted from the cell, and following secretion, all steroids bind to some extent to plasma proteins, the corticotropin, binding globulin, and albumin. This one um, uh, these are actually proteins, no? So all steroids bind to these plasma proteins. And for this table right here can be found in your book. Just read your book. On the right side, on the left side, these are the representative hormones, the cortisol, aldosterone, and androgens. And on the right side are its biologic effects. So just read on that one. And for this illustration right here, as I've mentioned, cholesterol is actually um, the conversion rather of your cholesterol to pregnenolone is the rate limiting step, 'di ba? I've already mentioned that in steroid biosynthesis. So cholesterol is being converted to pregnenolone by your cholesterol desmolase. That's the rate limiting step. Okay? And the for the the final step in the steroid synthetic pathway leading to production of your aldosterone is this one, the conversion of your 18 OH hydroxycorticosterone to aldosterone by the enzyme aldosterone synthase. So this is the final step in the steroid synthetic pathway leading to the production of your aldosterone. Now, that's for the mineralocorticoid class. The condition associated with with a defect in aldosterone production would be your uh, congenital adrenal hyperplasia. No, whenever there's this type of enzyme disorder, this will actually cause a decrease in the cortisol and aldosterone production. So this actually clinical presentations actually or depends on the affected enzyme. So 95% of this condition, 95% of congenital adrenal hyperplasia are a result of 21 hydroxylase deficiency. So almost 95% no um occur no occur for this kind of case. So 21 hydroxylase deficiency, this is the most common reason for your congenital adrenal hyperplasia. Now for um, there's actually the most severe form of your CAH, which is called the congenital lipoid adrenal hyperplasia, in which the synthesis of both gonadal and adrenal cortical steroids is markedly impaired. The lipoid CAH may be caused by a defect in the P50 side chain cleavage. And for the Okay, I've already flashed that one. So this is the final step, not for the final synthesis of your aldosterone. So for the to recap, for your mineralocorticoids, this is actually synthesized in the zona glomerulosa and they regulate the electrolyte concentrations of your extracellular fluids. So the most important mineralocorticoid, as I've mentioned, is the aldosterone. Why? Because it maintains sodium balance by reducing excretion of sodium from the body and it stimulates reabsorption of sodium by the kidneys and potassium excretion. Now, your aldosterone secretion is stimulated by the following. If there's a decrease in blood volume or blood pressure, di ba, I've already mentioned that this will activate your RAAS pathway, your renin-angiotensin-aldosterone system, which is the major stimulant. And also, aldosterone can be stimulated if there is hyponatremia or low blood sodium levels. And also if there's hyperkalemia or rising blood levels of your potassium. And of course, if there's a production of your ACTH, this would also in turn stimulate the aldosterone secretion. Now, to recap lang class, these are the four mechanisms of aldosterone secretion. First would be your renin-angiotensin mechanism, in which the kidneys, specifically your juxtaglomerular apparatus of your kidneys, will release the renin. This is actually an enzyme which would convert the angiotensinogen protein from your liver to angiotensin 1. Your angiotensin 1 is actually converted by your angiotensin converting enzyme to angiotensin 2, in which in turn stimulates aldosterone release. Now, the second mechanism would be the plasma concentration of your sodium and potassium, which directly influences the zona glomerulosa cells. Of course, it's um, uh, actually understandable na class. So if there's hypernatremia, so I mean hyponatremia, this would stimulate aldosterone secretion. And if there's hyperkalemia, this would also stimulate aldosterone secretion by increasing the secretion of your potassium, no, by the body through the kidneys. So the third mechanism would be your adrenocorticotropin hormone, which would cause a small increase of aldosterone during stress. And also this one right here, class, is actually a hormone, the atrial natriuretic peptide hormone, which inhibits activity of the zona glomerulosa. So this has an opposite effect of your aldosterone. Diba, aldosterone, it will resorb potassium by the potassium sodium by the kidneys. Your atrial natriuretic peptide, on the other hand, will actually cause the sodium loss, no, from the body. So it will not reabsorb your sodium, rather it will secrete or excrete your sodium from the body. So this illustration right here shows that, for example, I've already mentioned that whenever there's stress, it would release your corticotropin releasing hormone, no, and which would in turn release your adrenocorticotropin hormone. And this ACTH will stimulate your adrenal cortex to produce your aldosterone, no? And for example, if there's decreased sodium, increased potassium in the blood, or whenever there's decreased blood volume or decreased blood pressure, the kidneys will sense it by producing renin. So a cascade of pathway is being activated and will in turn produce your angiotensin 2, which will help no in the production of your aldosterone, which would stimulate the increased absorption of sodium and water and also increase potassium excretion. So just remember, class, that wherever sodium goes, water will follow. So for example, if we reabsorb sodium, then we also reabsorb water, leading to an increase in the blood pressure and eventually increase in the blood volume. So for and also for this one, this diagram right here, whenever we have the opposite effect na pod class, whenever we have increased blood pressure or blood volume, the actually there would be a release of your atrial natriuretic peptide, which has an inhibitory effect. So this will help in the sodium excretion from the body because it will lead so whenever there's excretion of your sodium, so this will lead to decrease in the blood pressure or blood volume. So for the action of your aldosterone, I've already mentioned stimulate sodium reabsorption by the distal tubule and collecting duct of the nephron and promotes potassium and hydrogen ion excretion. Now this also increases transcription of your sodium potassium pump and increases the expression of your apical sodium channels and the sodium potassium chloride cotransporter, and it also expands the extracellular fluid volume. For the regulation of your aldosterone secretion by the RAAS pathway, for example, if there's dehydration or hyponatremia or hemorrhage, no, whenever there's blood loss, there would be decrease in the blood volume and also decrease in the blood pressure. Now, the juxtaglomerular cells of the kidneys will sense it. They will produce renin. Your renin, this is actually an enzyme. This will convert, renin will convert angiotensinogen. This is a protein produced by your liver, will actually convert, no, will be converted to angiotensin 1. Now, angiotensin 1 will be converted by the angiotensin converting enzyme in the lungs to produce your angiotensin 2. This angiotensin 2 will actually lead to the constriction of your arterioles. Now, if there's vasoconstriction of your arterioles, so of course, there would be increase in the blood pressure until the blood pressure will return to normal. And if there's increase angiotensin 2, the adrenal cortex will sense it by increasing the body's response would be to increase aldosterone. So in the kidneys, there would be increased sodium and water reabsorption and increased secretion of your potassium and hydroxyl ion into the urine, which would in turn increase blood volume and increase in the blood pressure. And if there's hyperkalemia, the adrenal cortex would also produce your aldosterone, no? It will increase production of your aldosterone, leading to increased secretion of your potassium and hydroxyl ion into the urine. So for the role in diseases of your aldosterone hormone, if there's complete failure to secrete aldosterone, there would be dehydration, low blood volume, and worst case scenario would lead to death. Hyperaldosterone states, on the other hand, will contribute to your hypertension. This is associated with increased blood volume. Now, for your increased production of your aldosterone, we have primary causes and secondary causes. Your primary cause, example would be your Conn syndrome. An example of this would be your unilateral na adenoma. This is actually a benign tumor which would lead to increased production of your aldosterone. And also, if there's nodular hyperplasia of your zona glomerulosa, of course, it's understandable. So there would be increase in the aldosterone production, leading to hyperaldosteronism. hyperaldosteronism. For your secondary cause, which would be your cirrhosis, ascites, and nephrotic syndrome. So this right here, class, is pronounced as ascites, not ascites. For the signs and symptoms would be the following: headache, hypokalemia, causing muscle weakness, and also hypernatremia, hypervolemia, nocturnal pyuria, and hand cramping. Diba, I mentioned earlier where sodium goes, water will follow. So that's why there's nocturnal pyuria because of increase in blood volume. And for the Con syndrome, this is actually, I've mentioned earlier, this is a unilateral adenoma, a benign tumor of the adrenal gland causing a condition known as hyperaldosteronism. So when both adrenal glands are making too much aldosterone, the condition is called bilateral adrenal hyperplasia. So just take note, unilateral adenoma, benign tumor, unilateral lang ang affected class. When if there's bilateral adrenal hyperplasia, of course bilateral, from the word bilateral, both adrenal glands na are making too much aldosterone. Okay, let's just skip that one. For the treatment, we have a surgery for adenoma. This is actually just a benign tumor, and for hyperplasia, we can do medical management by giving spironolactone. And okay, class, for your assignment, just read the mechanism of action for spironolactone and its role um, in preventing the hyperaldosteronism. For the diagnosis, we can have the following criteria. If the plasma aldosterone to plasma renin activity is greater than 25%, no, in patients with hypertension, they have actually more than 25% of them have high plasma renin activity. I mean, sorry. I have to correct myself, no. 25% sa patients with hypertension actually have low plasma renin activity. And the aside from PA greater than 25%, the low plasma renin fails to increase with volume depletion, and also high aldosterone fails to decrease with saline or angiotensin inhibition. For another lab test, we can do urinary potassium excretion. This is actually a screening test for aldosteronism, and in patients with hypertension and unprovoked hypokalemia, if there's a production of more than 30 milliequivalents per day, that would be hyperaldosteronism. And if there's less than milliequivalents per day, less than 30, there would be increased renal potassium retention. And for your upright PA and PRA ratio in a fluid-deprived patient, overnight dehydration increases your plasma renin activity. And following volume expansion, the 2 liters of normal saline over 4 hours, this will suppress your aldosterone, di ba? And for the values, if more than 25, that would be primary aldosteronism. For your captopril suppression, di ba, captopril is an ACE inhibitor, the angiotensin converting enzyme inhibitor. So whenever we use captopril, so this is actually a confirmatory test, and it will suppress, di ba, the aldosterone level. So within 3 hours of taking 50 milligrams of captopril, that's 1 milligram per kilogram, if there's still high aldosterone, there would be aldosteronism. And if it is suppressed, then patient has other forms of causes na nag-hypertension ang patient. And for 18-hydrocorticosterone, if there would be more than 100 na nanogram per deciliter, patient may have aldosterone producing adenoma or can have idiopathic hyperaldosteronism, diba? When we say idiopathic, it's unknown. For adrenal imaging, we can have CT scan or MRI just to visualize if there's a tumor, no, that causes the hyperaldosteronism. So for this one class, I leave you to read on this one. So just take note na for primary hyperaldosteronism, there's increase in aldosterone, there's decrease in renin, and increase in serum potassium. And if it's an renin secreting tumor, of course, there's increase in both. Kay renin secreting tumor nga, di ba? Renin increase, aldosterone increase, and your serum potassium levels is decreased to normal ang levels, as well as this one. For your Addison disease, this one naman is your hypoaldosteronism. Your Addison disease actually, no, is the disorder that occurs when your body produces insufficient amounts uh, of your aldosterone, no, or hormones produced by your adrenal glands. So in Addison pod class, your adrenals produce little cortisol and also insufficient levels of aldosterone. So in Addison's disease, there's decrease in aldosterone, increase in renin, increase in serum potassium. In Cushing syndrome naman, we have decrease in aldosterone, also decrease in renin, and also normal to decrease na serum potassium. In other mga conditions, just read on the other conditions. For the Liddle syndrome, pseudo-hyperaldosteronism, itong Liddle syndrome, it may resemble primary aldosteronism, but aldosterone level the I class is low, and there's actually absence of hypertension. And this Liddle syndrome is actually caused by a mutation in the amiloride sensitive sodium channel within the renal, no, collecting duct. So, nephro ang problem nito, leading to enhanced sodium reabsorption and increased potassium secretion. So, that's for Liddle syndrome. Okay? Keyword nito class is pseudo-hyperaldosteronism. For your lab diagnosis, we can do a CTH assay because it has a pulsatile fashion, meaning naga-increase, decrease levels ang body niya, and it has a diurnal variation. It is highest at 8 a.m. no, sa morning, lowest naman paggabi, 10 p.m. to 12 midnight. Okay? And for sa 'di ba sa zona fasciculata, they synthesize glucocorticoids. The most important glucocorticoid is your cortisol rather. So this maintain blood glucose by lipolysis and gluconeogenesis and glycogenolysis. 'Di ba? You've already know the difference between the three. Gluconeogenesis, the production of glucose from other sources other than carbohydrates. Glycogenolysis, diba, the breakdown of your glycogen to produce glucose. Lipolysis, the breakdown of your lipids, diba, from the term itself. So the most tissues are target cells, and the only hormone that inhibits the secretion of ACTH is your cortisol. Now, for cortisol, 90% of which bound to your CBG, no? I mean, this is actually the cortisol binding globulin, which is called the transcortin and albumin, and also 10% of which are free or unbound. No, 90% bound to your CBG, your transcortin, and your albumin. 10% are free or unbound. And this actually is the effect, no, of your glucocorticoids in the body. So whenever there's production of glucocorticoids, this will stimulate the gluconeogenesis, lipolysis, the breakdown of your protein or your proteolysis, and then there would be insulin resistance. And so, di ba, whenever there's insulin resistance, the cell cannot take in glucose, no? Because, di ba, insulin helps in the cellular uptake of glucose. So, whenever there's resistance, so there would be high levels of glucose in the body, no? And let's go back. Also, in glucocorticoids, there would be decrease in inflammation because this is actually, di ba, anti-inflammatory. However, a patient can have a decreased immune system or immune function, which would render the patient no immunocompromised, prone to diseases. And your metabolic response to fasting, no, in gluconeogenesis, there would be from amino acids, there would be increased expression of the enzymes and also mobilization of stored fat and its use in beta oxidation and the production of ketone bodies. Now, glucocorticoids are used to alleviate inflammation because it inhibits production of your prostaglandins and leukotrienes. Kulang ito ng E-class. Leukotrienes, which mediate inflammation. No? The prostaglandins, leukotrienes, mediate inflammation. So, these glucocorticoids help, no, by inhibiting the production of these inflammatory substances. So this occurs via stimulation of an inhibitor of phospholipase A2, which is needed for your prostaglandin synthesis. Your glucocorticoids are used to alleviate inflammation, and they also reduce the effects of your histamine. So whenever we say na decrease in inflammation, it will decrease in the permeability of your capillary membranes, thereby it will reduce the swelling. And so this is the mode of action, no, of your glucocorticoids preventing preventing inflammation. No, it will inhibit the production of your prostaglandin, so leading to reduction of your inflammatory process. So for this one, circadian rhythm, it will actually is increased. Plasma cortical concentration is actually increased, no, in between during the morning. And for the diseases associated would be your Addison's disease, which is a destruction of 90% of the adrenal cortex. And this is actually secondary to your ACTH deficiency, or there's abnormality of your hypothalamus pituitary axis. And the low baseline cortisol levels at 8 a.m., no, and also there would be elevated ACTH greater than 200 picogram or picogram per ml for Addison disease. And for the symptoms, 100% can have the following symptoms: weakness, fatigue, anorexia, and there would be weight loss. For 90%, there would be hyperpigmentation. 50% can have nausea and diarrhea. For 10%, they can have pain because of the calcification. And for the test, we have the baseline cortisol, ACTH, and cosintropin administration. Just read on that, class. For the serum cortisol level, we can do fluorometric assay. This is actually in assay developed by Nelson and Samuels, which is based on a technique first developed by Porter and Silver. And we can have the radioimmunoassay and the chemiluminescent assay, and also um, the high performance liquid chromatography with tandem mass spectrometry. And we can do also basal cortisol level from you can get baseline cortisol between 8 to 9 a.m. Patient lies supine, and then um, if there's adrenal insufficiency, then there would be less than 3 microgram per DL. For the random cortisol, there would be less than 10 microgram per DL for adrenal insufficiency. For your ACTH stimulation test, it can be taken any time of the day, and we can give um, 250. So we get first serum cortisol baseline, and then we administer 250 microgram cosintropin. After 30 and 60 minutes, we collect serum for cortisol, and the normal response class would be more than 18 to 20 micrograms per deciliter at either point. And then we can also do metirapone test, the overnight metirapone test, which inhibits your 11 beta hydroxylase. This actually prevents conversion of 11-deoxycortisol to your cortisol. We can do this at 12 midnight, and also 8 a.m. We get blood for the cortisol and 11 deoxycortisol no, for at 8 a.m. For the normal levels class, for the 11-deoxycortisol, there would be more than 7 micrograms or 200 nanomoles per liter. For abnormal, of course, it would be less than 7 micrograms per DL na um, 11 deoxycortisol accompanied by decrease no na less than 5 microgram per DL na cortisol. For the CRH test, we get baseline ACTH and cortisol, and then we give 100 micrograms of your CRH, and then we collect blood every 15 minutes for 60 to 90 minutes, and the normal value would be more than 20 microgram per DL na cortisol. The corticotropin na plasma levels will usually peak at 15 to 30 minutes, and cortisol usually peaks around 30 to 40 minutes post CRH injection. For cortisolism, we have Cushing syndrome. This is actually a group of clinical and metabolic disorders characterized by adrenocortical hyperfunction, and there would be excess production of your glucocorticoids and um, androgens. So this is the primary and secondary hypersecretion of your cortisol. So for your secondary hypersecretion due to hypothalamic problem, so no, ang problem is in the hypothalamus. So there would be um, increase levels of your CRH, ACTH level, and cortisol level. So the negative feedback mechanism will fail. And for the secondary hypersecretion due to pituitary problem, the effect would be CRH levels low, tapos si ACTH levels high, as well as the cortisol levels. And for the primary hypersecretion due to problem with adrenal cortex, ang levels naman niya CRH low, ang ACTH niya low, and cortisol levels high. So just know the difference between the three. If a problem is hypothalamic, pituitary, and sa organ itself, if sa adrenal cortex mismo. So this Cushing syndrome, this is a classic picture of your patient with Cushing syndrome. There would be truncal obesity, no, or central obesity, in which there would be fat deposits in the body. There's also a buffalo hump deposited in the body. There's actually a moon face, no, the deposition of your subcutaneous fat in the cheeks and the submandibular area. Pansin na para good class ang patients with prednisone use. In patients with prednisone use, they can have moon fascie, no, fascie meaning moon face, and they can also have striae, mga stretch marks, no, in layman's term, stretch marks, no, they can have striae, purple striae, and also blood glucose levels will rise chronically, causing adrenal diabetes, and of course, um, 'di ba pancreas produce the pancreas, no, where the beta cells are found, will actually, 'di ba, they will release your insulin, and there would be destruction of your beta cells, no, for this condition. For Cushing syndrome, so this is a classic picture of your Cushing syndrome. The moon fascie, mga striae, purple stretch marks, no, truncal obesity, mga chubby cheeks. For Cushing's disease, this is actually a state of glucocorticoid excess resulting from an ACTH secreting pituitary adenoma. Most commonly, this is iatrogenic in origin. Meaning sa iatrogenic class would be physician-induced. Iatrogenic, induced by someone, no? Mura siya purposeful, ana. So, however, it may be due to ectopic production or of CRH or ACTH by a tumor, or due to a primary adrenal malignancy. For the diagnosis, we can do urine-free cholesterol, and This is actually a sensitive indicator of endogenous cortisolism, and when serum cortisol exceeds the capacity of its carrier protein binding, free cortisol levels rise rapidly, which would increase the free cortisol filtered into the urine. And this is affected by hydration, about 3 to 5 liters per day. We can also do 17 hydroxycorticosteroid using the urine. So this is not affected by volume changes, and we can also do 24-hour urine cortisol measured by your tandem mass spectroscopy, and this is the most sensitive and specific for excess cortisol. And this is collected overnight. The urine is collected overnight from 10 p.m. to 8 a.m. No, and we also should get creatinine. For dexamethasone suppression test, um, as cortisol substitute, suppressing ACTH if the pituitary gland is normal, and cortisol secretion if the adrenal gland is normal. So we can do overnight na dexamethasone suppression test, 1 milligram at 11 p.m., which suppresses the early morning ACTH stimulated rise in cortisol. And this is the suppressed free cortisol is around less than 3.6 microgram per dl between 8 to 9 a.m., which is a negative test. For the CRH stimulation test, this is helpful in distinguishing types of Cushing syndrome, the central disease versus primary adrenal syndrome. So in 8 a.m., we get serum cortisol and ACTH level, no, following um, the giving of CRH. And for this one, so in CRH stimulation test, if the cause is adrenal, meaning this is actually an ECTH, independent Cushing syndrome, no? Ang cause is adrenal. So there would be decrease in ACTH and increase in your cortisol. Okay, ang problem itself is the adrenal. For your ACTH-dependent Cushing syndrome, the primary cause would be your pituitary or ectopic, no? From other areas. May ectopic talaga. Hindi siya from the gland itself, no? Or from the organ itself. Kundi may other site siya, kaya ectopic. So there would be increase in ACTH and increase also in your cortisol. For the gonadocorticoids or your androgens, di ba, as I mentioned earlier, this is synthesized in zona reticularis. Your DHE, dehydroepiandrosterone, is sulfated to um, DHEAS by sulfotransferase. The androgens are the following, and the estrogens are the following. The androgens contribute to the onset of puberty and the appearance of secondary sex characteristics as well as sex drive in females. Men can have less than percent of uh, testosterone, and women can have 40 to 65% of testosterone. So this is the pathway, no, in the production of your androgenic steroids. So women produce estradiol and DHEA, and also men have testosterone as well as dehydroepiandrosterone. For the action, it will lead to the in men, no, it will produce androgens help produce testosterone androgens, which in turn help for the growth and survival of the genes. For this one, this is the male secondary sex characteristics, in which this is the age group in which the testicles begin to enlarge and the scrotum turns darker and coarser. So this is the age group, and this is the what happens during the development of your male secondary sex characteristics. And this is also the girls' development of the secondary sex characteristics, and up to what usual age range, no. And for the excess, if there's excess, there would be infertility, there would be feminizing effects by inhibiting pituitary gonadotropins, and also this would also lower If there are lower testosterone levels, there would be loss of muscle mass, there would be decreased hair growth, there would be decrease in the testis size. Okay. And for the adrenal androgens excess in females, also there's infertility, and also masculinizing effects. There would be hirsutism class, hirsutism, and there would be production of excessive hair, acne production, male pattern baldness, menstrual um, irregularities, or sterility. And for the diagnosis, we have the following. And the next part class would be your adrenal medulla, which will I will upload later.